Welcome back. Today we're looking at a safety document, one that maps out the high-risk anatomical zones for dermal filler injections.
Yeah, this is absolutely critical stuff, but the tone, I think, needs to really match the danger we're talking about.
I agree. Let's get right into it.
Okay,
So the first point is that the material, it does a good job identifying the nose and glabella as the main danger zones, statistically speaking.
it gives the numbers, right? 56.3% for the nose, 27.1% for the glabella.
Exactly. But the weakness is that it doesn't really translate those statistics into, the urgency you feel in a clinical setting.
Right, the data feels a bit academic. It's just numbers on a page. It lacks that immediate visceral punch.
And when you're talking about retinal survival time, which is just minutes,
The percentage doesn't really capture that second-by-second reality of the situation.
so the suggestion is to heighten that urgency. We have to connect the anatomical risk to the sheer speed of the catastrophe.
And a concrete way to do that is to talk about volume. Studies show it only takes something like zero point zero 0.04 to zero point 0.12 milliliters of filler,
A tiny amount.
a minuscule amount to travel up into the ophthalmic artery system. Link that fact directly to the immediate signs, the sharp pain, the sudden vision loss.
And then stress that practitioners must know exactly where the supraorbital and supratrochlear arteries are for an instant, precise intervention.
It needs to feel like a ticking clock.
Okay, let's move on to the second point. This is about duplex ultrasound, or DU. The document brings it up, which is great, but it feels like it's mostly discussed for complication management.
After the fact, you mean? Like you use it to confirm there's already an obstruction.
Yes, to identify that absence of flow or the tardus parvus waveform, it's positioned as a rescue tool.
And that's the weakness here. I think that's a huge missed opportunity because this technology should really be about prevention, not just cleanup.
Especially given how much facial vasculature varies from person to person.
Exactly. So the suggestion is to reframe that entire section. DU should be advocated as a mandatory pre-procedural tool
For mapping.
for precision mapping. So an actionable suggestion is to highlight that DU lets the injector see the vascular structures before they inject.
So they can confirm the needle path is safely deep on the periosteum or, very superficially in the dermis.
And you completely avoid that high-risk subcutaneous plane. It makes safety proactive, not reactive.
Right, a much stronger position.
Definitely.
All right, and the final point. This one is about procedural mastery and the types of fillers being used,
Yeah, the document focuses a lot on hyaluronic acid, on HA fillers.
which makes sense. They account for over 81% of reported visual complications, probably just because they're so widely used.
And because they're reversible with an enzyme. But that's the weakness. The audience could easily develop protocols that only work for HA.
Right, but what happens when you're dealing with calcium hydroxylapatite or polylactic acid?
Exactly. Those are not reversible in the same way. It's a totally different ballgame, and the risks are permanent.
So the suggestion is clear. True mastery means having robust contingency plans for non-HA complications.
For sure. A concrete way to frame that is to encourage training that covers the multidisciplinary protocols needed for non-HA filler ischemia.
So you're talking about what to do when hyaluronidase just isn't an option.
Yes, things like established recommendations for using systemic measures, like intravenous vasodilators, alprostyle, things like that. The plan has to be comprehensive.
Okay, so to quickly recap the adjustments for the document. First, for the nose and glabella, focus on the speed of the complication, not just the stats, to really drive home the clinical urgency.
Right. Make it feel immediate.
Second, reposition duplex ultrasound. It's a non-negotiable preventative mapping tool, not just for post-event cleanup.
Proactive safety.
And finally, expand the discussion on mastery. It has to include material-specific protocols for non-HA filler complications.
You can't just rely on hyaluronidase.
Urgency, preventative imaging, and comprehensive material coverage. I think implementing these steps will solidify this as an essential resource.
I agree. We look forward to seeing the revisions.